Station 11. Kangaroo births are wild. Oh, that's good. Next year, spooky season is Halloween animal births. Station 11 is a show about a post-apocalyptic United States that is set 20 years after a pandemic flu killed 9 billion people. In this scene, one of the main characters, Jeevan, wakes up in a makeshift birthing center after he passed out nearby in the snow. The birthing center is run by a woman/former doctor named Terry, who lost her medical license due to some sort of Ponzi scheme before the pandemic. Is her name Mary Tally Bowden? Sorry. Oh. That would be awesome. Yes, all for animal births, yeah. My daughter, who loves animals, wants me to do an animal birth video that she can be in with me. Oh, there's definitely funny births in many shows. It's just this was like a not meant to be a funny one. Anyway, maybe this one won't be as heavy. I love that this is a makeshift birth center and it's clearly like set up in a Bed Bath & Beyond. Like if it was the apocalypse and you needed to set up a birth center somewhere, I feel like a Bed Bath & Beyond would be like the ideal place. You have so many options for tools and, beds and bedding and towels and... You got beds, you got baths, you got the beyond. All of these people are birthing at the same time. Does it stink in Bed Bath & Beyond? Honestly, that should be everybody's faith. Go help someone. I don't know how. What am I? No. This is scary. This is my spooky season. I like his scrub top choice. I'm not gonna lie, I would not let that person hold my baby when his, her, their, I don't know, face looked like that. They looked terrified. Nope, give my baby back. Oh, well, okay, maybe if I was birthing a twin, I would let them hold it. Have y'all seen the news story about the OB-GYN doctor who she was in labor and there was an emergency and there was not another OB-GYN in the hospital and she like left her bed with her IV in and helped with another patient's delivery while she was in labor? His face is funny. No, don't cut it, clamp it first. No nerve endings in the umbilical cord. It's very thick and gristly to cut, and sometimes people don't really expect that, but no, there's not any nerve endings because I'm feeling it's not like physically a part of the body. I love the birth tub in the sporting goods section. Yeah, that's funny that they're all like having a baby at exactly the same time because it's like I've worked in like one of the busiest hospitals in Texas and there wouldn't be that many people actively delivering at the same time. Karin says the music is great. It is, and it's going to get you copyright claimed when we put this on YouTube, so. Everybody's default, just breathe. If you don't breathe, that would be bad. I'll stop for ads and we'll talk about this, but Karin said, Jeevan would be all of us since you watch MDJ, but I feel like all of you would be far more equipped than this. Your eyes wouldn't be like just at holding a baby. They would just do that when you knew what was happening and, oh my gosh, they're abrupting, but I don't know how to help. That's what it would be. Now, whoops, sorry. My computer's freaking out. Excuse me. Now we're blurring things? Oh my gosh, you're so scary. Come here. Now that is spooky. They're saying, hi, Pax. You say hi?
Hi.
How was your second day of school?
Good.
Where'd you get those? Whoa, that's so scary. Let me see. No. You scaring the chat? No. No. All right, give me a hug. I'll be back inside in just a minute. Mwah. Thanks for coming to show me those. What's happening? Okay, so she said dystocia. That could either be labor dystocia, meaning not progressing in labor, or shoulder dystocia, meaning the head's out, but the shoulder won't come out. Shoulder dystocia is what they're talking about. So actually the first step in managing a shoulder dystocia would be something called McRoberts, which is just pulling the legs back as far as possible. And what that does is open up the pelvis a bit more. So that would look like this. So because what's happening is that as the head comes down, the pubic bone is here and the shoulder has gotten stuck underneath the pubic bone. Pulling the legs up as far as possible while someone's on their back or flipping them over on hands and knees will open up the pelvis more. So there should be like a before and after of a rotating. All right, so the pubic bone here, sacrum here. Once the legs go back, then you can see how the pubic bone turns into a different angle, and the space here between the pubic bone, it's actually right here that you're looking at the space. That space is now wider, so the shoulder hopefully can come through more easily. You're always just trying to increase the AP diameter, anterior, posterior, front to back diameter of the pelvis, or decrease the shoulder. I can't think of the right medical term. You're either trying to increase the AP diameter, so anterior, posterior of the pelvis, increase the space in the pelvis, or decrease the shoulder to shoulder diameter of the baby. So you want collapse the shoulders is one thing that you can do. Sometimes you can turn the baby to change the positioning a little bit. Or you can do something called delivering the posterior arm. So if baby's coming through and if I'm the baby and my shoulder here is stuck on a pubic bone, then that's my anterior arm, that's the one that's stuck on the pubic bone. So as the person who's assisting with the delivery, I can put my hand inside, find the baby's shoulder. This is not comfortable if you don't have pain control, obviously. Find the baby's shoulder and follow it up to the antecubital space, which is the elbow. And you want to do that because you don't want to pull the arm the wrong way. And that's very easy to do because babies can be in all kinds of weird positions. Once you find the antecubital space, you're going to push on it because that bends the arm. See how pushing here bends the arm? And when the arm of the baby inside bends up towards the shoulder, then I can grab the hand from the vagina and pull the arm out. Okay, right? So, sorry, I'm probably sweaty, but what this does, and this is the wrong arm. This was in my description, the posterior arm. This one's the one stuck. But what that does is, look at the distance between my shoulders when I'm like this and when I'm like this. See how much less distance is here? So once that arm is out, it can help to get the baby out because it's a smaller space. Does that make sense? Something else you can do is suprapubic pressure. That is, because it's the pubic bone, in front of the pubic bone, or more towards mom's head from the pubic bone, you can feel, and if you can feel where the shoulder's at and push on it, that can also decrease this space between the shoulders. Does that make sense? So she's not managing this correctly because you want to keep the legs back, even when you're doing the other maneuvers, because that's giving you more space in the pelvis. At least giving you more space between where the shoulder is stuck, which is behind the pubic bone, symphysis pubic, and sacrum, or kind of pelvic curve. And why is this dangerous? Because when the head is out, but the rest of the body won't come, you could be having a decrease in blood supply for the baby. It is an emergency, but you have a little bit of time. You don't really want this to go on where the head's delivered for 10 minutes and the baby's not out. 3 minutes, you're starting to get anxious. 5 minutes, I'm really like, we need a solid alternative plan, which includes calling for help, getting to an operating room, and figuring out what in the heck we're going to do if we can't get this baby out. And yeah, so if the head is out, like from the vagina, and the shoulder is behind the pubic bone, you still have the umbilical cord going inside, but there's lots of compression there. So you could be, you're not always, but you could be completely compressing the oxygenation flow to the baby. Someone asked how easy it is to dislocate a shoulder. It can happen, and honestly, in this situation, it's not a bad thing. A dislocated shoulder is much easier to heal from than hypooxygenation that goes on for a prolonged period of time. So there are instances, sorry, that's an airplane. There are instances where you would purposefully break a clavicle to decrease the space, and those aren't your first go-tos for sure. You really want to try to avoid that if you can, but at the end of the day, a broken bone or a dislocated shoulder, if it's what fixes this problem, is better than the alternative. That's interesting. So the outcome that we have from Karin is that the mom didn't survive and the baby did, and that's a weird shoulder dystocia outcome. That's bad writing from a medical standpoint, because a shoulder dystocia, unless it goes on for a prolonged period of time, which would be long enough to kill the baby, is not something that is inherently or immediately life-threatening to the person delivering. So unless they had to go in and do surgery, but at that situation, the chances of the baby surviving is pretty low. So it's an interesting outcome to have the baby survive and the mom not, when it's a shoulder dystocia. That was the problem. Would it be possible to do a C-section at that point? So I'll walk you through, and I talked a little bit about this when we talked about the Georgia neonatal decapitation case. So when I take my oral boards, we all have to go and defend cases that we've done in front of a board of already board certified OB-GYNs, and it's very intimidating. But in the process of prepping for that, and usually during the test itself, they will run you through, okay, you do this for a shoulder dystocia, doesn't work, can't get the baby out. What's your next step? What's your next step? What's your next step? And they'll keep pushing you until you get to the point of, I have no other options. And we can talk about that. It's gruesome and happens incredibly rarely. But first step is McRoberts, putting the legs back to increase the front to back diameter of the pelvis. My typical go-to next step is a combination of suprapubic pressure, depending on if the person that is in the room with me is able to effectively do that or not. And I'm also starting to feel for that posterior shoulder so that I can work on delivering the posterior arm, because that tends to be the most quickly and safely effective management, in my opinion, and according to a lot of the data that we have on this topic. Then you can move on to other maneuvers if that doesn't work. One of them is called corkscrew, and that's turning the baby. See if I can find a picture. It's called a Woods corkscrew. So this might be good to show. Let's see if that effectively displays why this helps. Oh, look, a whole PowerPoint. Yeah, so they say not a maneuver. Pulling harder than usual is not a maneuver, right? You can't just pull and get it unstuck. And what that's going to do is cause nerve damage. Now, sometimes you get nerve damage, and this leads to something called an Erb's palsy. Sometimes you've probably seen people who have this. It's not uncommon in the grand scheme of birth injuries. It's not always because somebody pulled too hard. It can just be a product of how stuck the shoulder was. But you don't just pull to fix shoulder distortion, because you can't fix that by pulling, but you will cause an injury. Here's your maneuvers that we were just talking about. So McRoberts is moving the hips back, and then that opens up the pelvis a bit more. So you can see in this photo the same thing that we were just looking at. There's your 25 or 26 millimeter distance. Once the hips are back, it's 28 now. So you have a better distance between the front and back. Suprapubic pressure. So this is the shoulder that's stuck behind this pubic bone, and when they push, that decreases the shoulder to shoulder diameter. I'm trying to find the word for that. I think it's it's bothering me now that I think it's excuse me while I Google my medical things. Acromion. Okay, so biacromion diameter. There we go. That is what I needed. Biacromial diameter. Okay, that's the word I've been looking for. Yep, so see the distance? And this is showing exactly what I was just showing you earlier. Once that posterior arm is out, the distance biacromial. This wouldn't technically be a biacromial anymore. It's acromiothoracic then, but anyway, okay, that's meaningless. This is not what the point is. Gaskin, this is what I said when you could put the patient on all fours. It's safe, it's rapid, effective. It can be more difficult if somebody has an epidural that's really dense, but it's not impossible even then, and that can help release the anterior shoulder. Okay, Rubin maneuver. This is rolling fetus to one side, trying to change where that shoulder is and possibly get it to dislodge. I have never heard of a Pringle maneuver. We'll see what that is. Okay, so Rubin is, you find the posterior shoulder, same way as I was saying earlier, but instead of doing that in order to find the posterior shoulder to find the arm, you push on that posterior shoulder. Posterior means back side, the one facing the spine, and you push on it, and that rotates the baby around to the other side, and it's like, it just sometimes can dislodge that shoulder. Wood screw is essentially the same thing, except you're finding the front of that shoulder. So the posterior shoulder, the bottom shoulder, but you're pushing on the front to basically like corkscrew the baby out. And reverse is, I don't understand the difference between this and the Rubin, but some people describe it differently. This is delivery of the posterior arm, like I was talking about. So decreasing the diameter, anterior shoulder will help collapse. Flexing the elbow, this is what I was saying, you got to find that antecubital space, push on it to make the arm come up, and then deliver that to avoid fracturing the humerus. Although in the event that you can't do that, fracturing the humerus is probably preferential to being hypoxic. Clavicle fracture, If you've attempted any two movers without, okay, this is just for people who are learning, but anyway, yeah, there you go. That's an interesting thing to discuss. So you go through all those maneuvers, do them again, still not coming out. In your oral boards, they're going to push you. What's your next step? What's your next step? Okay. So you can, sometimes people talk about cutting an episiotomy. I find this not to be something that ever helps when I have a really bad shoulder dystocia, because I generally feel like my hand is fairly thin and able to get in. So the only reason that you would do that is if you could not get your hand around the backside of the baby's head so that you could feel for those arms and things like that. The next step that they will talk about is something called a Zavanelli. Zavanelli is where you basically do a C-section, and I'll keep talking, but everyone's an ad. So do a C-section, and it seems like, okay, this is be easy, but it is incredibly difficult to get the head back in through the cervix and take the baby out the other way. This is not something I have ever done and hope I never have to do, because it's very difficult and almost always associated with bad outcomes with both, or at least the baby. I'll show you. So you basically have to reverse what we call the cardinal movements of labor in order to get the baby back in. So once you get into the cesarean, once you've started it, you're essentially going to, I'm trying to find a picture, have to do this in reverse. So these are the cardinal movements of labor. These are what happen in the process of labor to allow the baby to come out. And if you need to get the baby back in, because now you have to do a C-section, you're going to do it in reverse, right? So you haven't gotten to this part or this part. You've probably had restitution. That just means they've turned. So this is once the head is out. So you need to basically turn the baby to where its face is facing down. That would be reversing the complete extension, or reversing the rotation that happens, restitution that happens after the delivery of the head. And then you would have to push the baby back up into number 5 here. Okay. And then you need to reverse the rotation that happened and get the chin to tuck back down. So see the difference here with this extension of the head, and this is not extended head. So you have to get the neck to be flexed back down to a chin to chest position. And then you have to get the baby back up a little bit higher, which is reversing the descent process of labor. And then you have to get the baby to not be engaged in the pelvis, which is a very tight place and not always very easy to do. So this is not something that's easy to do even once you get into the operating room. And because you've had this happen for a reason, it's often that there is a baby that is very big, or a pelvis that is very small, or there's something else going on that has made this happen and not be able to be fixed with all of the maneuvers that typically work. So this is like a worst nightmare scenario. However, in the process of your oral boards, they're going to say, okay, great, you tried to do a Zavanelli and baby won't come out. Now what? So you can let your imagination run wild with what are the options at that point. The old-timey answer is, what was a chainsaw built for, right? You've probably all heard this. It was developed to cut the pubic bone to get babies out when they were stuck. That's not in modern times usually going to be something that we do, but it is described. It's not something I'd be willing to do because I don't have training to cut through the pelvic bones like that, and there's a lot of bleeding, and the morbidity and mortality rate the baby's not going to be living through that, and the chances of the person who is delivering living through that are incredibly low. So the other thing that they will go through, and I won't describe this in detail, but you can let your brain continue down that path, is, okay, well, this baby's been stuck now so long, it is now certainly going to be stillborn. We can't get it out any other way. It's not alive anymore. What do we do? And you can process that. Obviously, these are not things that we like to think about in obstetrics, and they are not things that I hope to ever see or have to do, but at some point it does become, I've got to keep this person alive even though I was not able to keep their baby alive. And that's sad and terrible, and makes me thankful for modern medicine that it happens so rarely that we have to even play through the scenario and think about it. But what would be the highest risk that's generally considered when you have to try and pull them back the other way? My first thought would be the baby's face and umbilical cord, extra chances of bleeding for the parent. Yeah, I mean, the biggest risk is that by the time you're going to a Zavanelli, you have had a baby that's been stuck and likely under-oxygenated or not oxygenated at all for a minimum of 10 minutes, and the outcomes are going to be terrible. We can look and see. Mercury, yeah, that is what I'm saying in no direct terms. I'll look up Zavanelli outcomes. It's not that never results in a healthy baby when you have to do that. It's just after they've been stuck for that long. We have a hype train going. Thank you, everybody who's decided to subscribe. You can subscribe for free by linking your Amazon Prime account to Twitch and support one streamer per month. Hopefully that would be me. Or you can subscribe. Maybe you would be lucky enough to be gifted a gift sub in the chat. And otherwise, VODs will be posted in full for channel memories on the YouTube channel or for clips on MDJ Clips channel. I'm trying to log in here so we can look up outcomes. Hype train, sub, gift, bits. Y'all are awesome. Heavy subject for sure, but I appreciate the knowledge. Thank you. It is heavy. Yeah, I told him 2 minutes. I know, but he's doing something else or he'd be back out here. Don't worry. I'll be done in just a minute. This combo is way worse than any of the shows. I'm sorry. Am I muted? No, my audio is working. Karin pushed mute on her computer and then she's like, hey, MDJ, you're messing up the audio again, which I would believe because I always do. Let's see, Zavanelli. We need to give Karin a hand in the chat. Everyone who's subbed, sent her an emoji for sticking it out through all of these streams all the time and getting them ready for me. All right, here we go. Outcomes. This is up to date. My favorite physician reference. I'm going through all of that. Complications, drills, reducing. We're going to find outcomes. All right. 95% of shoulder dysocias are not associated with injury to the newborn. So that's good, right? These are big numbers. Most of the time, you end up with a healthy mom and baby. Injury among the remaining newborns was due to trauma, asphyxia, or both. So that's 5% of shoulder dystocias end up with some kind of birth injury. The following types and frequencies of newborn injury are described in studies with at least 100 cases, and they can overlap. So newborns may have both hypoxia and a brachial plexus palsy or something to that effect. All right, so transient brachial plexus palsy is the most common bad outcome of shoulder dystocia. So again, 95% have no bad outcome. In the 5% who do, about 15%-ish end up with a transient nerve palsy. So nerve palsy is what I was talking about earlier, where this nerve plexus, which is called the brachial plexus, that controls the arm and everything the arm does, is stretched. It's transient in this situation because it can recover function, and the degree to which recovery occurs is widely varying. It can be really bad, and it can really affect a baby's quality of life because it can, in some situations, be not transient, and that, I guess, would be permanent, and that means that for the rest of their life, they don't have normal function of their arm that had been stuck. Clavicular fracture, so the fractured clavicle, in the grand scheme of things, this is a fairly easy to recover from injury, and most of the time does not cause any long-term problems, which is good. But it is less common than a brachial plexus injury, which most of are transient. Also, humerus fracture, again, broken bones heal easier than broken brains. So while we never want to break bones in the process of delivery, that's never the goal when it's that versus a hypoxic injury or a brain injury that may not recover. You have to rank these things on which one is less permanent. My brother came out with one shoulder, the head and his second shoulder got stuck. They cut the cervix and broke his clavicle. Yeah. I don't know how cutting the cervix would help. Cutting a cervix is something we do when there's a head entrapment for a breech baby because the head's stuck in the cervix, so you could do what's called addertions, which is cutting the cervix. I'm not sure how cutting the cervix would help in a shoulder dystocia because the cervix isn't the problem. It's stuck on a bone. I don't know. But broken clavicle is certainly something we talk about. Permanent brachial plexus injury, 0.5 to 1.6% of those 5%. Hypoxic ischemic encephalopathy, this is brain damage related to asphyxiation, either, well, because the placenta and umbilical cord are compressed to the extent that there's not oxygen flow. And then death, 0 to 0.35%, meaning it's incredibly rare in the current day and age to have a shoulder dystocia that results in neonatal death, but it's not obviously impossible. My niece was born with hypoxic ischemic encephalopathy. She's blind, deaf, and has a G-tube and also cerebral palsy. Right, so that's on one of the more extreme ends. It can be a very, very bad birth injury. How common is a broken tailbone in delivery? I'd have to look up that number. Is there any research on whether these types of birth complications are linked to genetic conditions or other disorders? My son was breech when we found out he was almost 2. He has a genetic condition, slightly larger than average head, and I feel like he was breech for a reason. Being breech is definitely more common in pregnancies affected by a genetic abnormality of some sort, even if it's undiagnosed. For shoulder dystocia, the most common association is gestational diabetes, and the reason is because gestational diabetes changes the way that babies hold fat on their body, and it makes the shoulders wider compared to the typical diameter of the shoulders. But that being said, a majority of shoulder dystocias happen in people who do not have gestational diabetes. So does that make sense? Having it increases your risk of a shoulder dystocia. However, most shoulder dystocias happen in people who don't have it. And then let's see, maternal risk. Most common serious complication of a shoulder dystocia is hemorrhage and a 4th degree tear, which occur in 11% and 4% of pregnancies, retrospectively, in one study. Additional complications that occur rarely are most likely related to the maneuvers to relieve it, including symphysis separation, neuropathies, lacerations to the cervix or vagina, urethral injury, bladder laceration, and uterine rupture. So again, death is really uncommon in this scenario for the person who is giving birth. You can see if we go up, they talk about all of these maneuvers that we have gone through. This is one that I didn't really talk about. It's basically putting your hand under the stuck armpit. Under the opposite. So if this shoulder's stuck, you put it under the opposite armpit and kind of pull the shoulder out. So it's basically delivering the posterior shoulder instead of the whole arm, and it can help. They're also talking about using a sling, which would be like a catheter or something to put around that shoulder if you can't get it out. I've never seen that, but it sounds like this is a fairly bad outcome rate, but if you're getting to that point, it's, yeah, you're getting to the ones that are going to have worse outcomes. So procedures of last resort, this is like you've done everything again. You've done everything again. It's been many minutes, and it feels like many days, and now you do something else. So Zavanelli is replacing the fetal head into the pelvis. So that is what we were talking about earlier with reversing the cardinal movements of labor. They're talking about giving terbutaline. That's a relaxant for the uterus because it's much easier to push a baby back into the uterus when the uterus is not contracting against you. Success rate is highly successful, but I would assume associated with fairly significant bad outcomes. Abdominal rescue. Oh, yeah. So this is basically, you do a C-section, but instead of pulling the baby out like a C-section, once you get in, you push the shoulder under the pubic bone. Does that make sense? So you use your hand that is now inside the abdomen, inside the uterus from the top to push the shoulder under that pubic bone. Symphysiotomy is what I was talking about with separating the pubic bone. They say we recommend against this. As I was saying, I would not do it because although it increases the size of the pelvis and relieves the obstruction, even in remote areas of resource-limited countries where op rooms are unavailable, this is rarely, if ever, used because the maternal morbidity and lack of clinician expertise makes it dangerous. And it's described separately because of that. Anyway, I hope I never have to see most of those things that we just talked about. So, all right. Thank you all. I have things to go do, and I appreciate you being here for my very spooky dentist costume that I'm wearing today. I hope that you enjoyed the stream. I did, and I'm thankful. Thank you, Karin, for all of your hard work. She said, oh, she told me I had a palate cleanser I need to go look at. Hang on. Let me pull up the slides. All right. SNL is the day you were born. I will link this under my... Karin will post a link to this on the second channel community tab if you want to go watch it. I want to get off of here and go see my kids and get ready for the stuff we have going on tonight. So thank you, everybody. Karin, post that in the community tab. I will see you when I see you. I'll stream when I stream. Hopefully next Sunday or Monday US day, but maybe sooner if I decide I want to. Have a very happy Halloween.